I'd like to begin by thanking you for the honor of the invitation. My first trip to Guatemala, it's been a really nice visit. I'd also like to congratulate you on the opening of a new center, which, as I understand, is really focused on multidisciplinary care. So one of the things I'm going to highlight in my talk is give you a flavor of how we approach multidisciplinary care. And I think breast cancer, among all cancers, is sort of the prototype for that. My talk is not heavy on data or data slides. It really is a walk through how we approach patients with early-stage breast cancer. And I hope in the talk you'll see how the interaction between our multidisciplinary team comes together to provide what we think is the best care for patients. And this is constantly changing. I'm going to show you how we do it now. And hopefully you'll leave with a concept of how we work as a team. I also want to highlight a couple of the new things that we're doing towards the end of the talk that'll hopefully stimulate your interest in thinking about some new ways to improve the quality of life and treatment for patients with early-stage breast cancer. So it's great to exchange ideas, but one of the things I find most meaningful about opportunities like this is the friendships that are developed. So I'd like a specific thank you for Issa and Raphael, who've been wonderful hosts for me over the last several days and shown me a lot of what the country has to offer, so thank you. This is where we practice multidisciplinary cancer care. It's our new cancer building in Northeast Ohio. It opened almost 2 years ago. And we occupy the breast unit is on the 4th floor at the far side of the building. And it's where we run our multidisciplinary clinics. Every new patient is seen there. And it's really the place where everything kind of comes together. The patients stay in one place. All the doctors come to see the patient. I think the patients really like it. And I would say that the doctors really enjoy working there because we have at our disposal all the specialists when new patients come in. And I firmly believe, having worked in a cancer center for most of my adult life in training or as a staff, that cancer centers change lives. And it highlights the importance of what we do every day. And I'm going to show you a case that we recently treated. This is a 35-year-old female from the Middle East who was being treated for stage 3 breast cancer. It was reportedly ER negative and HER2 negative, and that was in 2014. And she presented to Cleveland Clinic because her tumor was growing on chemotherapy, and the doctors in the Middle East didn't know what to do. So we saw her, we re-reviewed her slides and repeated her exam and imaging, and we realized that the diagnosis was actually incorrect. In addition, on our evaluation, she had a contralateral breast cancer that was not picked up in the initial evaluation. So after that initial evaluation at the clinic, she was placed on HER2-directed therapy. She underwent a bilateral mastectomy with reconstruction. And fortunately, we were glad to see she had a complete pathologic response to the therapy. So a real success story. And this is her imaging. You see on the left side of the slide, the MRI at the time of presentation. You see a fairly extensive multicentric left breast cancer. And you actually see also a right contralateral axillary node, which we picked up on our evaluation. And then 4 months after being on HER2-directed therapy, you see the images on the right side of the slide, and you see a complete radiographic response, which was very encouraging. So this is what cancer centers can do. When you bring experts together, you can really have a big impact on people's lives. So our multidisciplinary model of care looks like this. We have a huge team, a lot of resources, both in the support area and in the physician and research areas. And this is a scheme of how we approach care with the patients in the middle of this model. In my opinion, multidisciplinary approach to care is the way to provide care to cancer patients. I think that what you've done with the building is critical because the space that we work in is critical. The doctors need to be comfortable. It also needs to be very warm for the patients, and having a nice environment is critical for that. No patient wants to be in a cancer center, but if we make the environment nice, at least for the time that they're there, it maybe not be so bad. Navigation is critical. We have a very robust navigation program that tracks patients from the time they enter with a diagnosis all the way through their final treatment. And this is critical because with all the different treatments going on, it can be very confusing for patients. We do an imaging consult on every patient when they walk in the door before they see the clinicians. And that's important because we have a direct interaction with the radiologists who are right in our clinic. And all of our patients on main campus are seen in a coordinated way where every patient is seen by all the specialists. And by the time the clinic visit is over, we can, in most cases, have a firm plan of care. One of the things we have used for the last 4 or 5 years as a surrogate for the quality of multidisciplinary care is a concept we call time to treatment. And so back in 2015, the Tulsa Cancer Center on the main campus began in every tumor type to track how long it took patients from the time they entered our program to the time of the first treatment. And in the United States, this has been a big issue, and there's multiple series reporting dramatic increases in the time to treatment in the U.S. over the last decade. And believe it or not, it's worse in academic centers. So we believe that it's our multidisciplinary approach has allowed us to drop the time to treatment 29% in the last 3 years. This is something we're very proud of. And I think the ability to offer patients care in a very timely fashion has numerous benefits to most patients. So this is something that is, we think, a surrogate for multidisciplinary care. So when we see new patients, this is what we do to evaluate them. We re-review the type of cancer they have. In breast cancer, the receptors on the cancer are critically important. We re-review every pathology that comes in from the outside, and we also either look at the outside images or in some cases repeat the radiographic evaluation. We have a very strong family genetics program, and they are embedded, as I will show you, in the middle of our cancer program. So all new patients that need genetics referral have same-day access to genetics, which can really expedite care, as I will show you. We also take into account their age and comorbidities and whether patients have any contraindications in their medical history to radiation therapy, because that can have a direct effect on the overall treatment plan. And then in terms of surgery, we look at their past medical history, their medications, and their surgical history, which also could impact both the surgery and the reconstructive options that patients have. In terms of a radiographic evaluation, we have 3D tomosynthesis, which has been used pretty extensively now across the U.S. In newly diagnosed patients, we use breast MR selectively, and I think more and more selectively. We tend to target younger patients, those with really dense breast tissue on mammography. We use it to evaluate the extent of disease in those considering partial mastectomy, maybe where there's confusion about the extent of the disease that could affect the type of surgery a patient would have. And we're more prone to use MRI preoperatively in patients with lobular cancers because they can be a little more insidious and infiltrative, making breast conservation more difficult. We use a lot of breast ultrasound. In all newly diagnosed patients, we do a breast ultrasound and an axillary ultrasound. And as we'll get into, in patients who have, some patients who have suspicious nodes, we're very aggressive about biopsying those nodes and leaving clips in to facilitate surgery down the road. And we'll talk more about that. And then we really reserve a metastatic workup for patients with clinical stage 3 breast cancer, or those who have symptoms that are suspicious for metastatic disease, and that's very much in line with the NCCN recommendations at the present time. As I mentioned, genetics is a huge part of what we do. Our genetics program is led by Dr. Karis Ang, who's a friend and a world-class geneticist. And in 2013, we actually brought the genetic counselor into our breast cancer clinic. And we pre-screen all the patients who are coming in, and those who meet criteria for genetic testing are given a genetics referral on the day of their initial evaluation. And we think this has really improved the care. In fact, we studied this, and what we have seen is numerous benefits to patients. And in the light of our discussion about time to treatment, we think part of our ability to get patients through in a more timely fashion, you see on the last row there, time from diagnosis to surgery, is significantly less after we brought those genetic counselors in, because we're no longer waiting weeks to get the genetic testing results that can impact surgical decision making. So again, bringing the multidisciplinary team to the patient, not having the patient wander around trying to find a genetics appointment. It's all brought right to the patient. So now I'm going to focus on how we approach patients as a team with early stage breast cancer. And at the core of this discussion is the idea that our approach is more and more tailored to the specific subtype of breast cancer. And I'm going to show you how in the different subtypes we tend to approach patients. And you'll see it's different for different subtypes. When I was a resident, and even in my early career as a staff member, the only indication to use neoadjuvant chemotherapy was to shrink tumors to facilitate breast-conserving therapy. And that's what we taught students and residents, and it was kind of the order of the day for many, many years. We wanted to convert patients from who would otherwise need a mastectomy with downsizing the tumor to make them eligible for breast-conserving surgery. And we knew that could effectively be done. But in the last several years, there's been two new indications that I think are really beginning to more and more influence our selection of patients for neoadjuvant therapy. One, in some subtypes of breast cancer, and I'll go more into this, particularly the HER2 positive type and the triple negative type, the neoadjuvant therapy can significantly downstage the axilla and limit the amount of axillary surgery that we need to do and limit the morbidity of an axillary dissection in many patients. And also in HER2 positive and triple negative breast cancer, we're learning that we can, by using neoadjuvant therapy, select patients for additional adjuvant therapy that can improve their overall outcome. And I'll highlight two examples of that a little later in the talk. There's some other considerations that we talk to our medical oncologist about on a daily basis in clinic. We consider surgery first, particularly in older patients when the intensity of the chemotherapy is uncertain and could be better informed by the final pathology, particularly node status and size of the tumor. We consider surgery when it's uncertain if a patient will require chemotherapy, again, often in older patients or in ER-positive patients. And the medical oncologists feel that the decision could better be informed by the final pathology because we really, for patients who ultimately will not need chemotherapy based on their biology, particularly oncotype score, we don't like to give them treatment in the neoadjuvant setting because they're all going to get treatment. So we, in many of those cases, will go ahead with surgery and reserve a decision about the adjuvant therapy based on the results of surgery. And we also consider the comorbidities of the patients when selecting patients for neoadjuvant therapy. So I'm going to walk through some of the different subtypes and to give you an idea how we specifically approach these. So the most common kind of breast cancer is estrogen receptor positive, HER2 negative. And for the T1 lesions that are clinically node negative, we always do surgery first. And most of these patients will have breast conserving surgery with a sentinel lymph node biopsy. A few, based on past history or family history or personal preference, will choose mastectomy with reconstruction. In those patients, we also do a sentinel node biopsy. For the T2, T3 lesions, we will sometimes do surgery first, or in these cases, we will do neoadjuvant therapy really to facilitate breast conservation because in our opinion, the response rates to most of these estrogen positive, HER2 negative tumors are not particularly that high and don't really give us a strong reason to, in many cases, want to proceed with chemotherapy. And we also are using, as I will show you, the oncotype score, even in node-positive patients, to select patients for adjuvant chemotherapy. So in these patients, T2, T3, ER-positive, HER2 negative, surgery first, or neoadjuvant therapy to shrink tumors. And if the tumors do shrink, we use breast-conserving surgery with sentinel node biopsy, or we do mastectomy with or without reconstruction. So what about the patients with ER-positive disease that are HER2 negative that present with node-positive disease? So many of these patients we will still consider surgery first, particularly if it's uncertain whether they'll need adjuvant chemotherapy. And for these patients, we'll do a modified radical mastectomy with or without reconstruction. And in the patients having a lymph node dissection, we'll do a lymphaticovenous bypass, and I'll show you a little bit more about that later. Or we do a lumpectomy with axillary node dissection and LV bypass. The nodal downstaging rate, as I will show you in these patients who go on neoadjuvant therapy with this type of breast cancer, is actually very low. So placing them on neoadjuvant therapy with the hopes of eradicating axillary disease is really not that helpful. We will consider neoadjuvant therapy in these patients or neoadjuvant endocrine therapy if the goal is to shrink the tumor to facilitate breast-conserving therapy. And we heavily rely in these patients on somatic gene testing, mostly oncotype in our practice, for determination of chemotherapy in patients with ER-positive N1 disease, which I would say is a big change over the last 5 years. And the reason we don't automatically rush to chemotherapy in these patients is the response rates, actually, if you look at published series, are fairly low. The overall pathologic complete response rates in ER-positive, HER2 negative are low, 7% overall pathologic complete response. The breast complete response rate is 9%, and the nodal complete response rate is 17%. So an argument made to really try to downstage the axilla to reduce axillary surgery is really not a strong one. So we have a multidisciplinary discussion and the decisions made about these patients. And one of the reasons we don't jump right to chemotherapy is that retrospective data, which looked at the value of oncotype in patients with low volume nodal disease in predicting response to chemotherapy. And this our medical oncologists rely on a lot, which again I think is a significant change from 5 years ago. This really wasn't being done much. But in low risk oncotype patients, even those that are node negative, shown on the far left slide, there's really no difference. In the intermediate scores, really no difference in those who get chemotherapy or not. And in those with high oncotype scores, we are very prone to use chemotherapy. The most difficult group in these patients are the intermediate scores, and I think our oncologists really rely on more traditional factors in those who end up with an intermediate oncotype score rather than relying heavily on the oncotype score. But certainly those with a high score get chemotherapy. Those with a low score often don't get chemotherapy. And again, in the middle, we use more traditional factors for selecting patients. But it's been a big change in how we practice. There's also been some interest. It's not influenced our practice, but there's been some studies now coming out about the concept of using oncotype for selecting ER-positive patients for neoadjuvant chemotherapy. And there's some who believe it could be useful in identifying patients who would benefit from chemotherapy who are ER-positive and HER2 negative. But the studies that have been done are small, and the data is actually a bit scattered. And there's been no consistent relationship shown between pathologic complete response and oncotype score. In addition, in our practice, there's a significant concern about the delay that doing that would cause in treating the patient. Because in the fastest circumstances, we can get the oncotype score back in about 2 weeks, 10 days to 2 weeks, and that in many cases we've already begun treatment. So we've not pursued this as a strategy, although it has some interest. So let's switch and talk about the triple negative type. For small tumors, again, T1N0, we do surgery first. We are much more prone in these type of patients to use neoadjuvant chemotherapy for reasons that I will highlight. And for the T2, T3, N0 or N1 patients, we almost always use neoadjuvant chemotherapy unless the patients have significant comorbidities, which would make us not want to do that. We do it to shrink tumors, to allow breast-conserving therapy. We also do it because in these patients you can get significant nodal downstaging. So a patient with low-volume nodal disease that's diagnosed prior to or at the time of their initial diagnosis, 41% of the time when they go on chemotherapy, they can be converted to node negative, and you can significantly limit the need for an axillary node dissection, which we think is very beneficial to patients. And then also in triple negative patients, we now know you can use the neoadjuvant therapy setting to select patients for therapeutic optimization after surgery, and I'll highlight that. We do surgery first if the intensity of the chemotherapy is in question. This is particularly true for older patients. So in the triple negative type, we see much better overall pathologic complete response rates, 23 to 25%, 25% in the breast, and the nodal complete response rate, as I mentioned before, is 41%. So we are much more inclined in triple negative patients who have T2 or larger tumors to go right to neoadjuvant therapy. And I mentioned selecting patients for additional therapy. And this is a study which was published in the New England Journal from Mark Toy's group in Kyoto. And they randomized patients who had an incomplete response to neoadjuvant therapy, to capecitabine or standard no treatment. And what they found is, particularly in the triple negative patients, that you saw an improvement in overall survival in those who went on to get oral chemotherapy. So in this case, it's an example of using the neoadjuvant therapy to select patients who will benefit from switching therapy. And by doing so, you can choose a higher risk population that could benefit from additional treatment. So yet another reason to want to use neoadjuvant therapy in these patients. And then finally, I'm going to highlight the HER2 positive patients. And obviously, there's a lot of activity in this space. But again, in the T1N0, it's surgery first. Most of these are lumpectomy or mastectomy. In some cases, with sentinel node biopsy. Again, in the T2, T3 patients, we almost always rely on neoadjuvant therapy in these patients for really the same reasons that we do it in the triple negative patients, for shrinking the tumor, nodal downstaging, and again, selecting patients who do not have a complete response for additional therapy. And there's several studies now, which I'm sure most in this group are familiar with, which have demonstrated that with dual-targeted therapy in the neoadjuvant setting, that we can achieve pathologic complete response rates that we've never seen before. In the NeoSphere trial, where we saw complete response rates of almost 40%, In the Trifina trial, we saw complete response rates in excess of 60%. This has generated a lot of enthusiasm for using these types of dual-targeted therapies in the neoadjuvant setting for HER2-positive patients. And our enthusiasm for using dual-targeted therapy was dampened a little bit, I must say, when the results of the Affinity trial came out, which was a trial which looked at adjuvant dual-targeted therapy. And there was a lot of hope that this trial would show extreme benefits in all categories of patients. But if you look at the overall survival curves, they really were quite similar. And the patients that really benefited were the higher risk patients, the node-positive patients and the younger patients. And so this type of data has tempered our enthusiasm for jumping to dual-targeted therapy in all patients. And we're a little more prone to sometimes use single agents in patients with comorbidities. And then for those without a complete response, we'll switch to TDM1, as I will show you. So this is another example of using the neoadjuvant therapy to select patients who would benefit from a different type of therapy. So this trial looked at patients with HER2-positive disease who had residual disease following neoadjuvant chemotherapy. So these are patients in that 40 to 50% group who do not have a complete response. The complete responders do extremely well, and we don't really feel there's a lot of need to add to their current treatment. But in those who do not have a complete response, this trial randomized patients to get a different type of HER2-targeted medication, TDM1, or they stayed on traditional HER2-targeted therapy. And what the trial showed was that when you switch patients to TDM1 in this setting, they have an improved outcome. So another example of how using neoadjuvant therapy can help us select patients for switching therapy to achieve a better outcome. So I'm going to leave this neoadjuvant discussion behind and switch to discuss some of the surgical issues and some of the advances we're making in surgery. And again, a lot of this is made possible by the multidisciplinary collaboration we have with our entire group, including plastic surgeons, radiation oncologists, and the medical oncologist. I'm going to first talk about lumpectomy. There's going to be a little bit of mention of margins, and then I'll discuss briefly lumpectomy following neoadjuvant chemotherapy. We'll discuss mastectomy and some of the new things we're doing in that space, which I think are pretty exciting. And then finally, we have a big interest in improving axillary management, and I'll show you some of the things we're doing in that area as well. So in lumpectomy patients, achieving a negative pathologic margin remains a topic of great interest. Most reported series still report margin positive rates in the 20 to 30% range, which is a big problem for patients because in those cases they'll need a second operation. There's been some improvement in this by the change in the guidelines which occurred over the last several years, which is what we follow, where we use for invasive breast cancer no tumor on ink. So we're no longer measuring margins in invasive breast cancer. If there's no tumor on ink, then that's sufficient, and we rely on the radiotherapy and the other adjuvant therapy. This has reduced our margin positive rate. For DCIS, in most cases, we'll still use 2 millimeters. There's been less study in this area, and this is what most of us feel comfortable with. We try to avoid margin re-excision because it delays adjuvant treatment, which we think is important. The adjuvant treatment delays can hurt patients. It also increases the cost of care, and patients have a lot of anxiety about needing a second operation. So we try really to avoid this. What about lumpectomy following neoadjuvant therapy? This has been a mainstay for a long time, and again, it's one of the main reasons we use neoadjuvant therapy, to shrink tumors down, to make them more amenable to breast conservation. If patients go on neoadjuvant therapy, we would have done a breast MR at the time we met them, at the time of their diagnosis, and then about 2/3 of the way through the chemotherapy, they come back and see my team, and we repeat the MRI, and it's at that time we begin to plan the surgery, the date for surgery, and the type of surgery that'll be done. They'll often meet again with a plastic surgeon on that day, and if needed, the radiation oncologist on that day, to sort of plan the overall next step for these patients. It's also a good time because there are this minority of patients who are not having a good response, and occasionally will abort the chemotherapy in those cases and proceed directly with surgery. And we do believe that lumpectomy is possible after neoadjuvant therapy if tumor shrinkage has been achieved and the tumor can be removed and still leave a healthy breast behind. So breast-conserving therapy after neoadjuvant therapy is a safe treatment, and that really is based on the far right side, which shows that the all-cause mortality in patients who have breast-conserving surgery after neoadjuvant therapy or have adjuvant therapy really have the same survival. It has been noted in this series and several other series that there may be a slight increased risk of local recurrence, but it has not, in general, affected overall survival. So for patients who are motivated to preserve the breast, we still will offer it to them after a discussion of this data. But it is a good option for some patients. So in the space of mastectomy, these are some of my thoughts on the way we approach patients now. We almost always do nipple-sparing mastectomy when it's possible. And the two things we consider in making that decision or recommendation are the location of the tumor. So tumors that are directly involving the nipple, obviously patients are not candidates for nipple-sparing surgery. Otherwise, we think they are from an oncologic standpoint. But we also work with our plastic surgeons because in patients, for instance, with severe ptosis, it's really not possible to achieve a good-looking breast while doing a nipple-sparing operation. So this, again, is a collaborative thing. We work with the patients and the plastic surgeons to come up with a unified plan. As I will mention, we're doing a lot more, almost exclusively now, prepectoral implant-based reconstruction, and this is simplifying our approach to reconstruction. And the recovery from surgery we're finding is much better. There are now reports that there's decreased effects of radiotherapy also in patients who receive prepectoral reconstruction. And as I said, this has really become a mainstay for us. And we have a program on the side which is working on sensory restoration after mastectomy. And initially, this was only involving patients having autologous reconstruction, but now we actually have an ongoing protocol to look at whether we can restore sensation in patients having implant-based reconstruction, which is exciting. So as I mentioned, we do a lot of nipple-sparing surgery. This is an example of a patient having a nipple-sparing mastectomy, and we think particularly for early-stage breast cancer, it's a fine option. This is Rizal Johan. He's head of the breast reconstruction group that I'm fortunate to work with. And again, they're doing a lot more prepectoral reconstruction, which avoids the mobilization of the muscle. The operations take less time. The patients have significantly less pain. The drains come out significantly sooner. And I think our general impression is the appearance of the breast is actually better. This is not suitable for all patients, but it is being utilized in a growing percentage of our patients at the present time. This is just an example of a patient on the operating table who's had prepectoral reconstruction. The left side's missing, but this is an example of what we can achieve with that type of reconstruction. We're working on sensory restoration as well, and I'm fortunate to work with 6 very talented plastic surgeons who do breast reconstruction for us. And now when they do free flap reconstruction using the DIP flap, they will bring nerves up and they will anastomose them to the nerves, the intercostal nerves. And we're prospectively studying the return of sensory function in these patients with the goal of minimizing the morbidity of sensory loss at the time of mastectomy. And I'm not going to talk much about it, but as I mentioned before, we're also working on sensory restoration in patients having implant-based reconstruction, which we're particularly excited about. We can talk about after, if you like. Another important role of the surgeon is the sentinel node biopsy, and things are changing dramatically in this space. And we're doing some research that we just published. Actually, I'll show you a bit about in terms of new ways to find sentinel nodes that we're excited about. In clinically node-negative patients, we perform sentinel node biopsy using technetium, and now we don't use blue dye anymore. We use a fluorescent dye, and I'll show you how we do that. For patients with 1 or 2 positive nodes having breast-conserving surgery, we don't do further axillary surgery anymore. We rely on radiation therapy and other adjuvant therapy. For patients with 3 or more positive nodes having breast-conserving surgery, we still feel they require axillary lymph node dissection, and we do that. We do intraoperative analysis of the nodes during those operations in many cases. And then certainly we still practice, although this may be changing, that patients who have a positive sentinel node at the time of mastectomy in general go on to axillary node dissection. But as I mentioned, in the face of what we're learning about the breast-conserving patients, this may be changing as well. So we're very excited about a new program for intraoperative imaging of sentinel nodes, and it's using fluorescence imaging. And we think it has some advantages over traditional procedures. I don't know if you can play the video over there. This is just a case that we recently did and have just published this. It was presented at the Southern Surgical. But this is a case of using fluorescence imaging to find sentinel nodes. We inject ICG, which is a fluorescent dye, very safe fluorescent dye, in the breast area. And this is basically real-time stuff. So I had just injected it, and now you can see with a camera right through the skin the path that the lymphatics are traveling. And you can see right there the lymphatics, and actually now we can see the sentinel nodes through the skin. You can actually see where this ultimately may go, where we may just image nodes and not even have to do surgery. But at the current iteration of the technology, through the skin, if you look on the black part of the screen, you'll see the sentinel node right there. And you can see it with the fluorescence camera, the node itself, and then we mark it exactly where it is. So there's no longer wandering around looking for the node, but we can see exactly where it is. And we make an incision. This patient was having a mastectomy, but during the surgery, you turn the lights down, and you can see the nodes like a light bulb in the dark. It makes it very easy to find them. And we just go and take them out. The newer technology, which I haven't shown here, actually allows fluorescence light and white light to overlay, so you don't have to turn the lights down. Once the node's removed, you see it light up like a light bulb, and then also it has, in this case, technetium in it, and the counts are 443. So this is something new that we're doing that I think you'll see more and more of. ICG is particularly attractive because there's no skin toxicity and there's no reports in 50 years of anaphylactic shock to this kind of dye. So I think it has a role, and you'll see more of this into the future. So how do we manage the axilla following neoadjuvant therapy? We believe, based on the results of the 1071 trial and some of the follow-up studies, that sentinel node biopsy, if done properly, can be used following neoadjuvant therapy. And let me tell you how we do that. For these patients, we use 2 dyes always, and we insist that the surgeons remove 3 or more sentinel nodes so that we get an accurate staging of the axilla. The other thing that we routinely do, and this goes back to the preoperative evaluation and workup, is that in patients undergoing node biopsy, we have the radiologist place a clip in the node at the time of the biopsy. And that is for the specific reason that at the time of the surgery after neoadjuvant therapy, we need to make sure that that clip node, which was biopsy positive before, has been removed. And so in many cases, we'll have the radiologist put a guide wire in to mark that node to facilitate the surgeon removing that node. There are other options, obviously, as well, including some of the wireless technologies which are now available, which you can use to mark these nodes. But the evidence is that if you remove 3 nodes, and included in those 3 nodes or more is that clip node, and they're all negative, that the reliability of the sentinel node is very high, and we do not feel an obligation to go through with a full node dissection in those patients. And so this is really a big change from 5 years ago, and really, I think, has improved the care of the patients and certainly reduced the morbidity of surgery in these patients. And then this is getting towards the end, but I'm going to show you about another exciting program which we're, I think, maybe one of 3 or 4 hospitals in the world that offer routinely now in an effort to reduce the sequelae of axillary surgery. For those who take care of breast cancer patients, and your patient had this operation shown on the left part of the slide, that's a complete old-fashioned axillary node dissection where everything is preserved, but except for the nerves and blood vessels that you need to keep everything is skeletonized. And we all know that this operation, particularly in those who actually also need radiation, are very prone to get lymphedema, which can be, the worst part of a patient's diagnosis, because a woman living or a man living with an arm like that can be very debilitated and really can compromise their quality of life. So we're working on a program we've been working on for over 2 years now, which is a new program we do in concert with the plastic surgeons. And the procedure is called a lymphaticovenous bypass. And I'm just going to take you through this, and I'm going to show you a short video clip of what we're doing. But at the time of the surgery, in patients we know are going to need a node dissection, we will do an injection of blue dye in the arm, and that's shown at the top figure. And the purpose of that is for reverse axillary mapping. So the blue dye is no longer put in the breast in these patients, it's put in the arm. And when you expose the axilla, anything you see that's blue is an arm lymphatic. It's not a breast lymphatic. And so in traditional axillary node dissection, everything went. You didn't know what was arm and what was breast. Now with the blue dye injection, we know the blue lymphatics came from the arm, and we preserve them when we can. In many cases, you can't, but we do the dissection sharply, and we put little clips carefully on those lymphatics. And while we're doing the surgery, the lymphatics will actually dilate up. And we also have modified the surgery, and I show that on the bottom figure. And you see some of the blue preserved arm lymphatics shown there. We'll also preserve some of the crossing veins that come through the axilla, which most of us were taught in surgery just to take didn't have any importance. Now we preserve them, and they're closely size matched to those lymphatics, and those become the recipient vessels for our anastomosis. And for these bypass procedures, you need a ultra microscope with a 40x magnification. And we're also using ICG in these patients I'll show you, to confirm the anastomosis. But this is the type of setup you need to do it. You need a good team of vascular surgeons who are comfortable working in this ultra super microsurgery environment. You actually don't need normal microsurgery tools. You need tools shown on the slide here, which are for super microsurgery. And often for these anastomoses done in the microscope, they'll use 12-0 sutures to do these, and you need a microscope that's like this. So this is what you see under the microscope after we've done the node dissection and we preserve the arm lymphatics. You'll see blue clip lymphatics, and you'll see some surrounding veins. And this is a picture of how we do the anastomosis. These vessels look large, but they're actually on the scale of about 1 millimeter. They just look big because they're under the microscope that's 40x. So this is, they'll cannulate with a 6-0 suture to cannulate the vessel. That's the blood vessel they first cannulated. Now they're cannulating the lymphatic vessel. And you'll see using 12-0 suture, we do a direct anastomosis of the arm lymphatics to small veins, and that will restore the arm lymphatic drainage in an effort to reduce the sequelae of lymphedema. And then we've been the first in the world to show, if you look at the bottom right figure, what we'll do after the anastomoses are done, the average number of these we do is 2.5, so 2 to 3 is the normal number that we'll do. After they do the anastomosis, we then put ICG, that fluorescent dye, in the arm. And under the fluorescent microscope, they confirm that there's lymphatic flow coming from the arm through the anastomosis, which has just been created. So we're just awaiting publication of our first reported series of almost 60 patients in whom we've done this, and the early results are very favorable. There's some skepticism about this and the long-term durability, but we feel that many patients, when offered this procedure, which adds some time to surgery, but holds promise to reduce the sequelae of lymphedema, is something that we're going to continue to pursue. Just a couple words about radiation therapy, because they're obviously a very important part of our team, and there have been some big changes in sort of how we approach these patients also. And adjuvant radiation therapy following breast-conserving surgery is radically changed from 10 years ago. And there's an increasing trend in our practice and many practices now towards shorter courses of radiation therapy. And almost all patients who get whole breast radiation therapy in our center now get 3-week whole breast irradiation. And we're using more and more partial breast irradiation. And for very low-risk patients, we'll use the intraoperative radiation therapy using the intrabeam from Zeiss, which is 20 gray delivered to the surface. It's done during the surgery, and for many patients will eliminate the need for any adjuvant radiation therapy, and those are our lowest risk patients. And then for those who meet otherwise ASTRO criteria for partial breast, we will use, Dr. Chirag Shah has pioneered the 5-fraction partial breast technique, which we're having very good results with and low toxicity, and the patients really like it. It's 5 fractions given over 10 days, and the patients are done. And in selected ER-positive patients over the age of 70, we also are omitting radiation therapy in selected cases after a careful discussion with the patient. And then with whole breast irradiation, we're obviously using more and more hypofractionated whole breast. We still treat the whole breast, but we're changing the schedule and the fractionation as shown here, and we know now that it's reduced the cost and reduced the treatment duration and the impact on patients. And there's, as was just mentioned in the last talk, a potential improvement in local control based on radiobiology, so something we continue to pursue. And then just one word about post-mastectomy radiation therapy. I think in general, at least in our center, we're more inclined now to use post-mastectomy radiation therapy based on some of the initial recent meta-analyses, even in patients with 1 to 3 positive nodes, particularly those who are younger or at higher risk for other reasons. We consider comprehensive radiation therapy in those patients. And the other indications for post-mastectomy radiation are shown here. So in closing, I'm going to go back to the patient I presented at the beginning, and this is the young patient that we saw in consultation from the Middle East. And one thing we find is that when patients have a good experience with the multidisciplinary team, they often continue to come back and seek long-term follow-up in the place where they were treated. And we have the fortune to continue to see this young patient. And at the time of her last visit, she's now 3 years out. and had at her most recent imaging event, which was a bone scan and a CT scan of the chest, abdomen, pelvis. We're happy to report she's completely NED, and so this was, as I said before, a complete 360 in her care, which has resulted in a dramatically improved outcome. And this is why the work you're doing at Integra, and I think working as a multidisciplinary team, is so critical to improving the lives of the patients that you treat. So thank you very much for your attention.